Welcome to the International HHT Guidelines webinar on pediatrics. Before we begin, I'd like to give you a little bit of background about the International HHT Guidelines. In 2008, Cure HHT hosted the first International HHT Guidelines Conference, which produced the first internationally recognized HHT guidelines in 2009. 10 years later, Cure HHT hosted the Christopher McMahon Memorial International HHT Guidelines Conference, which was only made possible by a very generous donation from the McMahon family. This event involved 12 months of literature review and topic team discussions with over 60 HHT physicians and patients from 15 countries. The results was the publication of the second International HHT Guidelines, published in the Annals of Medicine in September 2020. Cure HHT created fact sheets for each topic area, along with the guidelines recommendations, all of which have been bound in this comprehensive guide to managing your HHT. We are providing the first copy of this guide complimentary to anyone who's interested. If you haven't already received your copy and would like one, please complete the Join Us form on our website, and I will be providing that link in the Zoom chat. Now, I'd like to introduce our speakers. Dr. Adrienne Hammill is a pediatric hematologist-oncologist and director of the Cincinnati Children's HHT Center of Excellence in Cincinnati, Ohio. Dr. Andy White is pediatric rheumatologist and co-director of the HHT Center of Excellence at the Washington University St. Louis Children's Hospital in St. Louis, Missouri. Dr. Hammill and Dr. White were lead members of the Guidelines Pediatric Group, which recommended the now accepted standards of care for this topic area, making them the perfect speakers for today's conversation. And a special member of our panel today is Cassie Friday. Cassie's husband and 2 of her 3 children have HHT. She has joined us today to share her story and the importance of staying on top of your children's HHT care. At the end of the presentation, all 3 panelists will be available to answer your questions. So I now invite Dr. Hammill to turn on your camera. Or Dr. White, I'm sorry, turn on your camera, and we're going to start off with the poll. And the first one is, have your children been screened at an HHT Center of Excellence? And here are our results, Dr. White.
Looks like about half and half.
Yes. Okay. If you could share your screen.
Great, is that me?
Yes.
Okay, fair enough. Let me see if I can figure that out. I'm sure I can. Okay,
looks great.
See a slide that has red and blue on it that says HHT and pediatrics.
Looks great.
Okay, fantastic. So today, welcome everybody to our new guidelines discussion. We're going to start with a little bit of an outline. To begin, we're going to review a little bit about HHT, in particular how pediatric HHT may look. And then we will provide an overview of the pediatric recommendations that were included in the 2020 International Guidelines. After that, we'll have a short discussion about the use of checklists in HHT. And then we will hear from a parent-patient representative, actual live patient right here, and learn a lot more about their experience, her experience with her children. And then finally, we'll have some questions at the end. So let's get going because we don't have a lot of time. So a couple of things. HHT, hereditary hemorrhagic telangiectasia. A lot of you know a lot about this, but I'm going to just give some basics for review. This is an autosomal dominant disease, which means the genetics behind it are very well understood. And a dominant disease means that roughly there's a 50-50 chance of every child having this. It's a relatively common illness. We estimate its prevalence in the United States of about 1 in 5,000 people, but it is different in different countries, and in some scenarios it may be 1 in 10,000. There are, of course, other countries where it is more common. This illness is characterized by vascular malformations. You'll hear the word arteriovenous malformations, you'll hear vascular malformations, but they basically represent a poorly formed or malformed connection between an artery and a vein, bypassing a capillary. And they can be simple, they can be complex, and I'll have some diagrams of what those look like here. They tend to occur in certain organs. Classically, the skin, the nose, the intestinal tract, the brain, the lung, and the liver are characteristic for HHT. We know this disease is relatively underdiagnosed. Most people in the United States with HHT are actually unaware that they have it. So that is a problem, and that's why one of the focuses of, one of the main focus of the HHT Foundation is to get screening and get identified. We also know that there's a long diagnostic delay in those cases. So you may be diagnosed at birth, or you may be 70 or 80 by the time you're diagnosed. So it can be decades. The most common symptom of HHT is, of course, nosebleeds. We call that epistaxis. This tends to worsen with age, as does sort of the typical appearance of the cutaneous telangiectasia. And we have a few pictures to show you how that changes over the years. The diagnostic criteria currently are based on the Curacao criteria, and we will have a slide about that. And it's more and more easily performed. Genetic testing is available and is more and more easily performed these days, particularly for a patient from a family with a known HHT mutation. It can now, in fact, be done with saliva testing. Curacao criteria, most everybody is aware of. The diagnosis of HHT is definite if you have 3 or more criteria, suspected if you have 2 criteria, and is unlikely if you have less than 2 criteria. These were designed for adults, but I'll have a slide in a second about pediatric Curacao criteria. So those criteria are epistaxis or recurrent nosebleeds. They need to be spontaneous, recurrent, but there's no number associated with that. There's no amount of blood loss associated with that. So this is somewhat vague criterion, especially in pediatrics, where something like 50% of kids will have nosebleeds, even if they don't have HHT. Telangiectasia, telangiectasias, these are arteriovenous malformations that are present on the skin. They happen in characteristic spots in HHT, such as the lips, the tip of the tongue, the fingers. The third criterion is visceral involvement. That means a sort of a solid organ, such as the GI tract or the lungs or the liver or in the brain. And then finally, the fourth criterion is a first-degree relative. That means a child or a parent with known HHT. But of course, a genetic diagnosis will since bypass the Curacao criteria or will get you the diagnosis without having to worry about the Curacao criteria. Dr. Hammill and I, as well as several other physicians that you may know, worked on a study with Dr. Christy Powell, who looked at the Curacao criteria in regards to children, and her conclusion was, in fact, that the Curacao criteria do appear to reliably diagnose HHT in children who have 3 or 4 of the criteria, but that there's some variations in sensitivity. For example, the overall sensitivity is 68%, which is not a great number. The higher, the better in younger age groups. So it works better as you get closer to adulthood, but it's still reasonable. Let's talk a little bit about the manifestations of HHT with which many of you are directly familiar. The first is dilated blood vessels, telangiectasia. So these occur in most people with HHT before the age of 40, certainly about 30% before the age of 20. But I do think a lot of them are subtle and are missed in children. They tend to occur on the face, lips, ears, hands, forearms. In children, these findings may not be present yet, or they may be missed by the physical examiner, or they may be very minor. Here are some examples of telangiectasia on the lips. On one side, you can see an adult with plainly obvious telangiectasias on the lips. On the other side is a child with a tiny one. It is entirely likely that the child will grow up and have lips that look like the adult here. So the process of HHT is develops over time, and symptoms become manifest over years or decades. Here is another example. There's a spot on the tongue of one child on the left, and then a close-up of an adult with several telangiectasias in the papilla of the tongue. Right. Similarly, the cutaneous manifestations on the hands are different. You'll see the adult hand with the 3 fingers on one side. You see several telangiectasias there. On the other side, you can see 2 very small ones in a child in between the 4th and 5th digits. You can easily see how these could be missed by a physical exam. Nosebleeds are the hallmark of HHT. Most people have them by the age of 40. They tend to be the most bothersome symptom. The average age of onset of a nosebleed is about 12 years of age. But they can begin earlier. I've had children as young as 4 months of age with HHT have nosebleeds. They can be profuse or sparse, they can ooze, they can happen daily. It's worth noting that in children without HHT, nosebleeds are very rare in infancy, but by the time you're 6 to 10 years old, about half of kids have had at least one, and there are children who have recurrent episodes of nosebleeds that do not have HHT. But in children with HHT, about 1/3 of them have nosebleeds by the age of 10, and the vast majority, 80 to 90%, by the time they become an adult at 21, have nosebleeds. Pulmonary arteriovenous malformations. We believe that about 55% of adults have these. The data are not as well understood in children. Most articles will say at least 20 to 25% of children will have them. It's probably higher. But there are things that affect that number of reporting. So the problem with pulmonary AVMs in children and not knowing how many of them have it is that they may be asymptomatic and therefore don't get screened for them. They may be unrecognized. Some symptoms of pulmonary AVMs, such as exercise intolerance, might be mistaken for asthma. Blue lips and blue fingertips are actually kind of common in children, especially when you go to the swimming pool and stay in a little too long when it gets cold. The symptoms are also sometimes things like a headache and caused by other issues. So pulmonary AVMs, here's some diagrams of what they look like. Most pulmonary AVMs in HHT are what we call simple, meaning there's a single artery and a single vein. And so 90% of them will look like the 3 drawings, but some of them can be complex with several feeding arteries or veins. Here is a contrast image of the lung field, the vascular bed of the lung field, and I think you guys might be able to see down here is a pulmonary AVM. It has a feeding vessel of 4 millimeters across, and this clearly looks different than all the other little tiny capillaries that are present in the lung field. Here's a 3D reconstruction of what that would look like. Again, the typical pulmonary arteries come down to small vessels, capillaries. But here is a 3D reconstructed image of a pulmonary AVM. A little bit about brain AVMs. They occur also in HHT. We believe that about 10 to 15% of adults have brain vascular malformations. We don't know the exact numbers in children, but different reports have shown anywhere from 10 to 25%. It doesn't make sense to me that it would be more common in children. I think this is a reporting error, screening issue, or a selection bias, if you will. But needless to say, you can have central nervous system manifestations from the brain AVMs. but you can certainly have central nervous system manifestations from pulmonary AVMs as well. So a couple of things about the brain AVMs. If they rupture, they can cause an intracranial hemorrhage. We believe that is about a 1% risk per year or less. Other complications, though, end up being ischemic strokes from pulmonary AVMs, brain abscesses from pulmonary AVMs, and migraines from pulmonary AVMs. So really, the issue that we worry about having a brain AVM is the possibility of intracranial hemorrhage. The treatment options for those include conventional surgery, embolization, where we thread a catheter into the vascular malformation and occlude it with coils or glue, and radiotherapy, sometimes called a gamma knife or proton therapy, which we tend to avoid in the younger children. Those are options. So that's your refresher on HHT. I left out liver, I left out GI bleeding, because in reality, most children don't have those complications of this. So the second international guidelines, as Nicole already mentioned, included a group of at least 60 people, and we met for several days in Canada. We were almost in lockdown. It was kind of a precursor to our current lockdown that we might be having. But we focused on HHT for several days. And actually, we had done a lot of work beforehand trying to identify the types of issues and questions that were of concern in pediatrics to us. So here is the working group, the panel. And you can see in the front row, there's Dr. Hammill, and there's Marianne back. And we had a subgroup of the pediatric experts, and here we are. And this is the list of the people who worked on this. And this is where I think I'm going to hand it over to Dr. Hammill to continue talking about what the guidelines, the conclusions that we reached, and what they actually are. So let me stop sharing.
And while we switch speakers, let's launch our second poll, asking, have you used the pediatric HHT guidelines checklists? And Dr. Hammill, here are our results.
Great. So it looks like about a third of our listeners have actually used them already, which is great. About half have not, and a subgroup 20% didn't even know about it. So they'll learn something new today for sure. All right. So as Dr. White said, here was our group. There were 6 groups, and each came up with 6 recommendations. These represented the first ever guidelines for children from newborn to age 18. And this really filled a critical gap because the first set of guidelines initially published were general. They didn't say they were adults only, but it was very variable how people applied these guidelines to children. And it wasn't clear if children should be screened when they were little or only if symptomatic. And so we were able to work on those in this set of guidelines. The 6 guidelines that we came up with actually reviewed the diagnosis of HHT. So the first is, how should you diagnose it in children? There are actually 3 guidelines that discuss pulmonary AVMs in children, the screening, treatment, and rescreening. And then there are 2 guidelines that address screening and treatment of brain AVMs, or brain vascular malformations. So we'll jump right in. And the first recommendation, as I said, talked about making the diagnosis of HHT in children. And our recommendation was that diagnostic genetic testing be offered to asymptomatic children who have a parent with HHT. This means that they're at 50% risk. And this was actually based on some high quality evidence that shows that if there's a known familial mutation, the result of testing is definitive. You can either rule a patient in or out, even when they don't have any signs or symptoms yet. And the agreement was strong for this with 94%. There were a couple of clinical considerations that we wanted to bring up for everybody who's reading and using these. First is that an affected family member who meets full criteria should be tested first. This is usually a parent, but in some families it can be a grandparent if the parent is clearly already meeting the clinical criteria and we know the familial mutation. As Dr. White mentioned here at the second bullet point, the established clinical criteria are not necessarily reliable in young children because the most visible symptoms, nosebleeds and telangiectasias, develop over time and may not be fully visible until they're much older. And so you certainly cannot rule any child out for having HHT based on clinical signs alone. So those clinical criteria are great when the child meets them. If they're positive, it's really true, and you may not need to do the genetic testing. But if they don't meet full criteria, you cannot rule them out without a genetic test. Then it's generally accepted that when we're doing pre-symptomatic testing for genetic conditions, there should be a clinical benefit. And in general, most people agreed that the benefit would be you'd know which children need to go through our screening protocols that we'll talk more about in a few minutes. But the value of this actually varied from country to country. There are some countries who do not routinely do pre-symptomatic screening. And so in those places, it may not be so clear to do the genetic testing because they're not trying to decide who needs screening and who doesn't. And as always, all of these discussions should be discussed with patients and their parents to decide the right thing to do for that family. Our second recommendation moves on to pulmonary AVMs. And we agreed as a panel that we should screen for pulmonary AVMs at the time of presentation or diagnosis. And we also said, even in asymptomatic children, they should be screened, and all children who have known HHT either meet clinical criteria, have a genetic diagnosis, or those who have been unable to be ruled out because perhaps there is no familial mutation known for them, do need to be screened. So those patients who remain at 50% risk, unable to be ruled out, should undergo screening. And the quality of evidence here was moderate, but we had strong agreement on proceeding with 94%. And this evidence was primarily based on some case series that show that, as Dr. White mentioned, children do have pulmonary AVMs and perhaps in levels up to those detected in adults. And we had, again, clinical considerations include how to screen. So we didn't want to dictate that, but we mentioned the two most widely published and accepted approaches. I'll talk about those more in a minute, right here. So screening for pulmonary AVMs can either occur through pulse oximetry, the little sticker on their finger that gives an oxygen reading, plus a chest X-ray. Not pulse ox alone, as had been practiced by some practitioners previously, because pretty much everyone on our panel, on our pediatric panel, had at least one case where they had seen a normal pulse ox reading in a patient with a very large AVM, large enough to be picked up on a routine chest X-ray. And so that's why it requires the combination to be sure that the oxygen's not low and that there's not a large pulmonary AVM hiding there anyway. But, and I'll come back to this in a minute, pulse ox has been shown to potentially overestimate the oxygen levels in blood. And so it may not be as reliable as we all think. The other way that is commonly used, and I believe used by both Dr. White and myself, is what we call a bubble echo, or its official name, transthoracic contrast echocardiography, TTCE, or as I said, bubble echo. This is actually a semi-quantitative method for looking for pulmonary AVMs, but it does require a peripheral IV, which is something that no child wants, and it's hard for parents to watch have it placed. This is a very sensitive method for picking up pulmonary AVMs, and there's some discussion that maybe it's too sensitive, that it's picking up AVMs before they're clinically relevant. But it also allows us to see what might be coming over time, because some of the research does suggest that pulmonary AVMs in children will double in size in about 5 years. And so it gives us some estimation of when they might reach a clinically significant size. And then the last point here at the bottom, chest CT is not recommended as a screening method, but if pulse ox with chest x-ray or bubble echo are positive, that is the definitive way for us to know where the AVMs are and if they're large enough to require intervention. Recently, there was a paper that came out in the New England Journal of Medicine, largely because of all of the information we have gotten through the COVID crisis, that was able to compare pulse ox, so the little monitor on your finger, to the gold standard for measuring oxygen, which is an arterial blood gas. So actually drawing blood directly from an artery. And when they compared this for patients with a moderately low pulse ox in the 92 to 96% range, they found out that there were a significant number of patients who actually had oxygen below 88% on that gold standard test. And 88% is where they really do need an intervention. So even though their pulse ox looked okay at 92 to 96%, not normal, but okay, 4% of patients with light skin and 12% of patients with darker skin actually had critically low levels that really needed intervention. And just quickly, I know this is really busy, and I don't want you to get too overwhelmed, but here on the bottom here where it says pulse ox, these are the pulse ox readings from the fingers. And here was the true oxygen as measured by the arterial blood gas. And what you can see is that in general, they match. So here's a 90% pulse ox. And you can see that patients who read with a pulse ox of 90% actually had it somewhere between 97 and 73. So there certainly are outliers. Up here at 96%, which normally would be a reasonable pulse ox for an adult, you can see that the real level is somewhere between 99 and 82%. So again, a significant number of those patients need it. But if you have darker skin, it's actually lower. You can see there's a shift. And some of those patients are really in trouble here down at 72%. The big picture I want to show is that, that there is a trend that these things correlate. And so we can certainly use pulse ox as a reasonable placeholder, but we have to remember the limitations if there's any suspicion at all. And you can also see that when there are outliers, they are usually below these levels. So very few outliers high, several outliers low, regardless of race, regardless of what the pulse ox shows. And so this pulse ox tends to overestimate the oxygen level actually in circulation. And as I mentioned, there is a significant discrepancy between races, with this overestimation occurring 3 times more often in our patients with darker skin. So something to think about when we're using that as our primary method. So moving on to the next pediatric care recommendation. This is when we find pulmonary AVMs, should we treat them? And we said yes. If there are large pulmonary AVMs or pulmonary AVMs with low oxygen, we should treat them, even in children, to avoid the complications. And again, this is based on some case series that suggest that children can have serious complications from large pulmonary AVMs. And in that case, we recommend embolization for treatment, just as we would in adult patients. And there was strong agreement on this recommendation. Just like in adult patients, the way that we're currently doing it, if the pulmonary AVM has a feeding artery large enough to get into, usually 3 millimeters or larger, they are a candidate for embolization and treatment of that. And once they're treated, they still require follow-up in order to detect if that area reopens, if there's recanalization through the coils, or new areas, reperfusion of that area occurs. And so they do need close follow-up to make sure that the intervention worked. But there was no agreement on how to do that or how often to do that. The next recommendation is how to follow up pulmonary AVMs after if they're not treated. And so we recommended that, yes, in fact, asymptomatic children should be rescreened. And based on the information I already mentioned, that these tend to double in size every 5 years in one study, we recommended a 5-year interval for patients who had a negative testing, and potentially an earlier interval for those with intermediate or borderline results. So potentially a bubble echo with just a few bubbles, you might do a little bit earlier than 5 years. Or if a patient has a saturation on that pulse ox on their finger of less than 97%. So while in adults, most adult physicians don't really bulk at numbers below 95 or even 92%, we all agreed on our pediatric care group that a saturation below 97% in a patient with no other reason, so not currently having a cold, not currently wheezing or having asthma, that even a 96%, you should probably look earlier because something might be going on. Then we move on to our brain vascular malformation recommendations. And we did recommend that at the time of presentation or diagnosis, again, any child who has HHT confirmed by clinical criteria, by genetics, or remains at 50% risk, unable to be ruled out, should undergo screening. And again, this is based on low quality of evidence. I'll talk about that for a minute at the end. But it's based on case series where there is a risk of intracranial hemorrhage from these. And potentially finding them early allows us to intervene just as we can in adults. So while the evidence was low, we still had strong agreement with 86%. A couple of clinical considerations include that our first line screening is MRI, preferably with contrast, because that makes it more sensitive to look at the blood vessels. And we're looking for different types of brain vascular malformations. There are multiple that can occur. And we're trying to determine which ones are at high risk, high enough to potentially need intervention. The difficulty with an MRI in small children is that it usually requires sedation or anesthesia. And this was one place where we had a lot of discussion, lively discussion about the pros and cons of doing this. As I mentioned before, there are some countries, partially based on their nationalized health systems, that don't feel that this is necessary or appropriate because it is so rare to have an AVM. And we talk about 10% of adults and children having brain AVMs, sometimes more, like Dr. White showed you. There might be some overrepresentation in some of the literature. So somewhere around 10%, maybe 20% of patients have them, and rupture is very rare, as Dr. White had on his slide. We think it's less than 1% per year risk of rupture. So it's quite small risk that someone would actually have a ruptured brain AVM. And yet, if that does occur, it is potentially devastating, causing stroke, seizures, and even death. And people were very vocal, particularly patient family members, were very vocal that this is an unacceptable risk when we might be able to intervene. And I think in the end, we did vote that way and approve this recommendation. And finally, as I suggested, those brain AVMs or brain vascular malformations that have high risk features, high risk being risk of intracranial hemorrhage, should be treated. And again, the quality of evidence is low, but we know that these can be treated, even though treatment itself carries significant risks and requires a discussion. And we had strong agreement on the strength of this recommendation. Again, there were several clinical considerations for this. Again, needing to balance the natural history risk based on the type of vascular malformation that's been discovered, against the treatment risk. And for high-risk lesions like arteriovenous fistulas that have very high pressure directly going into a vein, these are at high risk of stretching out the vein and ultimately higher risk of hemorrhage. And so those most people felt did need to be addressed, as opposed to capillary telangiectasias, which are very small, lower pressure, and very unlikely to have any bleeding risk. We suggested that to have this discussion, patients and families should be referred to a multidisciplinary group who has specific disease and neurovascular disease management, particularly pediatric neurovascular disease, which is not that common. And then, centers with expertise are not that easy to find. And then the decision, again, should be discussed between experienced clinicians with the family and, if old enough, the child. And then treated brain vascular malformations require follow-up to see how they change over time, if they recanalize or reperfuse. But also some of the smaller ones may require follow-up, although we did not agree on how to do that. So here's just a quick summary of all of the recommendations I just went through. And you can see that overall, aside from the genetic testing, our quality of evidence is low, generally pretty low. And this is because there aren't enough publications in pediatrics. Dr. White and several of our colleagues were working together to try to change some of that and pull our experience with pediatrics, but it's not really out there yet. And then gladly, after a lot of discussion, our strength of recommendation was strong in all cases. We were able to come to agreement that these were appropriate recommendations. And we hope that you'll be able to use these guidelines to see that we now are trying to improve the quality and consistency of care across pediatrics, regardless of what country or what center you go to. As Nicole has mentioned, the full guidelines and support tools can be found on the website. And you can actually use these to improve the knowledge of people around you, family members, even your physicians, by printing these out and sharing them. They're intended for both clinicians and patients and families. Finally, I wanted to just touch on these checklists. Again, these are useful for both clinicians and families. And there are a number of these. There's one for each of the set of guidelines. They recommend that you start with the general one, checklist for my HHT care, and then pull the other ones that are appropriate. If you have liver AVMs, use the liver AVM handout. If you have significant bleeding, you can use the anemia group. Here are the two that are specific to pediatric care. There's both a My Child's HHT care checklist and a My Teen Years checklist for teens to start to take responsibility for their own. They actually list the same check things, and this is a 3-page thing, so it includes the guidelines on the back pages. Just looking closely at this really quickly, the first checkpoint on this list is, if we don't know if my child is affected, talk to the doctor about genetic testing. So that was our first recommendation. If they have HHT or it's not able to be ruled out, it recommends that you talk about screening for lung and brain vascular malformations. If they have lung vascular malformations, talk about treatment, talk about the need for AVM precautions. This includes prophylactic antibiotics prior to significant dental procedures and even cleanings, and then a plan for follow-up. If you have brain vascular malformations, ask to be referred to a neurovascular team with pediatric expertise to discuss this. And then finally, if all of your screening is negative, you're not due for anything for 5 more years, and you'll revisit the screening then. And with that, I think Dr. White and I would like to thank you for your attention, and we're going to answer any questions after we give Cassie a chance to share her family story.
Great, thank you so much. And Cassie, while you're bringing up your video, let's launch our last poll. And it's asking if have your children under 18 been fully screened either by clinical diagnosis or genetic testing for HHT?
All right, so it looks like the majority of people have received a genetic diagnosis, a few with clinical, and about 15% have not received a diagnosis or screening. Okay. So hi everyone, I'm Cassie Friday. I am an HHT caregiver. My husband, his mom, and 2 of our 3 kids have HHT. We're also a military family, so we have been to multiple different care centers, HHT centers of excellence, and even received care in other countries, just as the nature of the constantly on the move lifestyle. So I really just want to speak to the importance of trying to get to an HHT center of excellence if you can, and if not, making sure that you take your children's physician or their care team the guidelines that were presented by Doctors White and Hammill today. So we have actually been lucky enough to be treated by Dr. White and Dr. Hammill just recently. So we had our first child when we were stationed in Kansas, and she received a positive genetic diagnosis. Her grandmother had gotten tested first, and then we got our 4-year-old tested, and she was able to be seen at St. Louis with Dr. White when she was 9 months old for her first initial screening. And then we moved to Virginia, and we were not at an HHT center of excellence there. And so it kind of fell on me when we had our second child to coordinate with our primary care physician who was not familiar with HHT, and to coordinate that care, get the referrals for genetic testing, facilitate that, and then find some kind of pediatric team for cardiology or pulmonology to get him screened once his diagnosis was positive. And that was really difficult. I was printing off all the current guidelines and papers about HHT, and I kind of became like their medical care coordinator. And with 2 little kids under 2 years old and a job, and where our life is busy, and you don't need that stress on you if you don't have to have it that way. So while our care in Virginia was really excellent, it was just a lot more stress on our family to not be in a center of excellence. So like whenever we were seeing Dr. White in St. Louis, we were able to have a specific care coordinator who did everything for us. And that was the same with Cincinnati Children's Hospital and Dr. Hammill. They have an excellent care coordinator, and she was able to set up everything. We didn't have to think about a single thing. And you also didn't have to educate the physicians or primary care docs about what HHT is, or try to get the prophylactic antibiotic prescription, because these are the physicians who created these guidelines, and so they know it front and back, and they know exactly what to do, and the processes are very streamlined. We were able to go to Cincinnati Children's first thing in the morning, get all of our imaging done, and then we were able to have our clinic appointments and get the results of that imaging from the morning in the afternoon. And so it was a little bit of a long day, but it was actually very easy and laid back, and the flow was really pretty relaxed. So if you can get to a center of excellence, I highly recommend it, especially St. Louis or Cincinnati Children's. And if anyone has any questions about pediatric care or anything, feel free to reach out to me anytime. 2 of our 3 kids have HHT. Both have had positive bubble echoes, so they will be getting screened a little bit sooner based on their recommendations on the guidelines. And then our 3rd child has had genetic testing, and he is negative for HHT.
Awesome. Well, thank you so much. I really appreciate all of our speakers. Dr. Hamill and Dr. White gave a thorough overview of HHT guideline recommendations for pediatrics, and we're very grateful for Cassie and her willingness to share her story. So we do have quite a few questions that have come in, so we will go ahead and get started. So the first question we have here is, my daughter was tested at a children's hospital about a year ago. She was positive. They did follow-up tests to check her brain, lungs, and heart. This was not an HHT center. And so just wondering, should they double check by an HHT specialist, or is going to a non-HHT doctor sufficient?
Yeah, that's kind of a hard question to answer. I'll just, because we don't know the skill levels of whatever particular physicians they saw. However, I would say that most imaging and procedures are available for review, and usually centers of excellence will be happy to review any outside MRIs or outside bubble echoes that are reported to make sure that the interpretations are the same as ours. So it's pretty easy to do. We're willing to do it. But I will say most radiologists in the country who are looking at a brain MRI, for example, will be able to see an AVM or not. So I have pretty good faith in most other centers that are not centers of excellence, but we're always happy to offer a second.
And I would agree with that, in general, if there's something big there, they'll find it. We do manually review all of the bubble echoes that come from other centers, because sometimes the report is focused on an intracardiac shunt, because that's the reason that bubble echo is most commonly performed for ASD or PFO or some other intracardiac problem. And so sometimes they don't go out far enough to look for late bubbles. Sometimes they don't even see them when they're there. And so we always manually review them ourselves.
Great, thank you. So we have a question asking if there's any treatment for a 3-year-old or just a young patient that has daily nosebleeds where the bleeding is so extensive that they have developed anemia.
Dr. Hammill?
I'd say if they've developed anemia, yes, they definitely need something more. We would generally start with making sure that they're doing nasal toilet, just keeping it moist or squirting it. It's hard to do in a 3-year-old sometimes. But the other thing that we would do is get the child to our ENT, who works closely with us, to see what they can see and if there are other options, if there's a single site that's problematic, to potentially do some coblation, cold laser. I don't know at WashU what you all do.
Well, yeah. So other than hold pressure, which is really hard to do, and good nasal hygiene, when we do have problematic ones, we will either try a little local injection of something like Avastin or a sclerosing agent, or we'll use low laser energy ablation, but focal, because we're really worried
Right.
the induction of additional AVMs.
And another question along those lines is, what level of nosebleed problems for a child would be concerning enough to seek emergency care?
Yeah, I think that, there's emergency care. So this is something that probably doesn't stop bleeding for X amount of time. And that is going to be different for different patients, different for different parents' tolerance of how long a nosebleed should go on. And certainly if you end up with some symptoms that would suggest there's acute anemia that's going on, like loss of consciousness, passing out, shortness of breath while running around. So most families, I think, will be able to get a nosebleed, a bad one, under control, but occasionally they'll have to go to the ER. So it's a hard thing to define where that line is. So therefore, I'm not really answering it. I'm sorry, but it's hard to define. So something that most children with HHT have some family members with HHT, and therefore they have some experience with when a nosebleed gets out of control. And so I think you rely on your own individual judgment, but for going to an emergency room, usually it's something like anemia, loss of consciousness. And I don't know, Dr. Hammill, what do you think?
The other guideline that we use is about 6 ounces, like a small styrofoam coffee cup, because it can look like a ton if you're just using tissues, things like that. Not your coffee cup.
Yes.
That's too big. But it's hard to tell how much it is when it's soaked through a pillow while they're sleeping. It can be super scary. But if it's stopped, you're done. I mean, you can talk to your local pediatrician, or depending how close your HHT center is, get your blood count checked if it really seems like it's been significant. Again, if nosebleeds are causing anemia, I think we need to step it up and do more and start the child on iron.
Okay. So we have a question here asking about the benefit of knowing the exact family mutation. This individual says they weren't given that information, but they have confirmation that their daughter inherited HHT from their father.
I think the benefit of knowing the exact mutation is probably more for the physicians and the researchers to know, to analyze the potential mechanisms at play here. The fact that they know the mutation is important, though, for testing other families. It makes the genetic test much easier to do and much more important.
Yeah, I think as we're learning more, we're starting to notice more and more subtle differences between the underlying causes, even though they still all cause HHT. The one that really stands out from the others, though, is the SMAD4 mutation, because it comes with a couple of other syndromes that need to be watched for. And so it is important, if that's your mutation, to really to make sure that you know that and are getting the other care as well.
Cassie, would you want to speak to that? Because I know your daughters were diagnosed early.
Yeah, so our children have the mutation in the gene that encodes the protein endoglin, or ENG mutation. Sometimes it's also called HHT type 1. So I think I just saw it pop up asking if it's important to know what type of HHT a person might have. And so the types are based on the different mutations. So like Dr. Hammill said, if you have the mutation in SMAD4 that comes along with another couple of syndromes, then it's going to be important to know that. And that's a different type of HHT, but they're all, relatively screened the same and treated the same.
And I'd like to make a point of, right, yes, knowing endoglin versus ALK1 versus SMAD4 is important. Knowing that the mutation in SMAD4 is an exon 3 with a G to C mutation is more important for the researchers.
Mm-hmm.
Okay, great. So we have a question from someone in Greece, and they have 3 children, ages 5, 7, and 9. And they're asking if there's any other tests except for genetic testing that they can do at this age. And obviously, we're also talking about a country where there's not an HHT center currently.
If genetic testing is not available, any of the children who have symptoms, I'm assuming there's a family history and a parent based on that question, but any of the children who have symptoms definitely need to be screened. And by our current recommendations, anyone who's at 50% risk technically should be screened with both ideally MRI for brain and one of those 2 approved mechanisms, chest X-ray plus pulse ox or bubble echo for lung AVMs.
Okay, great.
Again, I would say, in Europe, things are a little bit different. Not everybody has kind of moved that far along. And so it's still up for debate. If you're able to get it, I think that's the only way you know for sure that there's not something there.
Okay. And then we have a couple of questions regarding brain AVMs and asking about follow-up screening, either, if the initial screening was negative.
Right. Well, the guidelines say that we should look at the new guidelines say that we should probably rescreen about every 5 years, but the reality is that's what the new guidelines say. In most centers will repeat screening about every 5 years or so. Probably we don't discover as many new AVMs, if any, and that data needs to come out. So we need to do a little bit more investigating about when brain AVMs develop and whether new ones develop over time or whether they're all present at birth or very small and they grow. Sorry, there's a helicopter landing on my roof, so I'm going to mute myself for a second and I'll switch to that.
Yeah, I think that was not a question we specifically addressed in these guidelines. We left it vague to kind of rescreen in 5 years. But I think as far as rescreening for brain AVMs, we did not get into it because we had enough difficulty agreeing to do it in the first place. The way that we've done it is everybody gets it again after puberty, and they get one in between if there's a family history of AVMs, once they're able to do it without sedation. So usually 9, 10.
Okay, great. We have a question specifically to Cassie asking how and when did you tell your children about their diagnosis, and what worked best for your family in that situation?
Good question. We have talked about it constantly, and we try to keep it very casual as well. I know sometimes people will see all the blood coming out of their nose and they'll panic, but we really try to keep very calm with them, and they see their dad getting nosebleeds very often, so they know just to go and get toilet paper or a baby wipe, and how to kind of stop themselves. We have a 4-year-old and a 3-year-old, and at those ages, they're able to do that, and they're working on pronouncing the full name of the disease. So we kind of practice that as a way to keep it fun, like, what do you have? They have HHT, and then what does it stand for? So we try to just keep it very casual. I don't really talk to them about specific symptoms. As long as all of their teachers know at their preschool, and their physicians that care for them here locally, that's the most important part. They just know what to do when they have a nosebleed.
Sounds great. So we have a question asking which centers of excellence are specific for pediatric patients, and do you need to go to a center that has a specific pediatric team?
That may be a question for you, Nicole.
Yeah. Obviously, we're biased.
Yeah.
I would clearly either go to St. Louis or Cincinnati. That's what we think. But you probably have the more up-to-date list and some opinions about that.
Yeah, and one of the things that we're actually, you all probably get our email next week, asking about pediatric care at the centers to determine, if there is a specific team of specialists, is there a freestanding hospital? Is it a children's hospital, or are they seen by the adult HHT center specialists? And so that's information that we do actually plan to include on each center's page in the directory to sort of help direct people. But it is my understanding that all of the centers do see children, they just don't all have pediatric specialists. Would you agree with that?
I think that is probably occurring. I think children are being seen by non-pediatric physicians. I'm sure that's occurring.
Okay. And I would say that it's a very different view that I get meeting often sick or symptomatic pediatric patients first, and then meeting their well parents who didn't know they had it, or things like that, as opposed to a primarily adult center where they're meeting adults who have HHT and their well grandchildren or children. So it's a little different view of HHT that you get depending which way you come into it, but eventually we all take care of all of them. So
Right. We are all physicians, so that
yes.
to some extent that helps. And it's a little bit of a philosophical question. It's almost the same thing as, should we see an HHT specialist doctor for our HHT, or should we see any doctor for our HHT? It's the same type of question. And part of it depends on the skills of those particular physicians. If you're going with somebody who's not sort of trained or certified in that particular area.
I think one difference, and sorry, Cassie, I'll let you talk in a second, is that if we have found an AVM, that there's more skill and expertise at the centers that do that a lot. And so so not necessarily me in the office to talk about HHT, because adult-based physicians who are experts in HHT could do that as well. But what about the proceduralists who are going to treat it? And I think that you can probably find that more rich experience at centers that see a lot of pediatric HHT for your child.
Yeah. And as a parent, I can speak to like having children being seen in a pediatric environment. While everyone's skill level may be great and all the care team is very competent, being in a pediatric environment that caters specifically to children can really just remove a lot of stress and anxiety from the situation during screening or care. They have child life specialists that come in to help distract your children, and it's just a more pleasant, happy environment. Our kids were treated overseas in an adult hospital, and it was a very different experience.
Okay. And so we have a question here that is someone's asking for their friend, but I think this happens in just families in general, where HHT is known to be in the family, but the children are not getting tested because they're asymptomatic or whatever the reason being. And so the question is, what's the most convincing argument to get someone to decide to test their children?
Right. Yeah, I was asked this question on Wednesday in the HHT clinic by a mother who said she can't get the rest of her family to get tested at all. And what's the most convincing argument? I'm not sure we have a good answer for that. Data is useful, but not always paid attention to, I believe. So I don't know. You guys have better convincing arguments to convince people to go to the doctor?
I mean, I think, we just say that, again, just because they don't have telangiectasias or nosebleeds yet doesn't mean they can't have something even big and scary inside. And unless you look, you won't know. And while most people think bad things don't happen to kids, I have definitely seen it. And I know that you have as well.
Yeah. And adults, there's, the patient yesterday, she's like, I can't get my older brother to go see a doctor, and I know he's got it.
So we're just going to ask two more questions. I know we're slightly over, but so one question is, and this is directed towards Cassie, how do you talk to your school nurse or local physicians about HHT for your children?
Right. So I usually come in armed with stuff from the Cure HHT website. I have just kind of like the checklist and those resources that Nicole has put in the chat. I have those printed out. Part of that is just because I know that not everyone is very familiar with HHT, but also because, we move around so much, it's just easier for me to keep all the records, with myself so that it doesn't get scattered around all over the place. But usually I first ask for familiarity with HHT, and obviously, they're very smart people. They're going to go up and look it up because you can't have automatic recall of everything that you've learned in your training, and they'll probably find the guidelines as well. But I just try to make it easy, and I have the guidelines printed. And I say, here are the guidelines. I also have the prophylactic antibiotic recommendations for our children that I give a copy to as well. And I say, this is what we need for our dentist appointment. Would you prefer to prescribe these antibiotics before we go to the dentist, or should I check with the dental office and see if they would rather do it? I just try to make it easy. But I think that making sure that you yourself are very informed about HHT and these guidelines is the most important part, so that you can kind of make sure that you're staying on top of things as well.
Okay, great. And so I think our last question, and I know there's a lot of questions that didn't get answered. We will try to get back to you next week with some resources and answers if we weren't able to do it today. But there is a military family living in Germany. They have a clinical diagnosis of HHT. Their 7-year-old daughter was screened at a German center of excellence using MR imaging. It was negative for AVMs. They were told they'd need to be screened after puberty, and if negative again, she wouldn't require additional treatment if she remains asymptomatic. And their question is, should I have her screened again at age 12, which is that 5-year interval, or should she wait until puberty?
12 might be puberty. My daughter went through puberty at 9.5. So you never know exactly. I think there's, the exact details are probably less important for time, the beginning of puberty, the end of puberty. I would say probably in this space, I'd wait until, the teenage years, 15, 16, somewhere around there, before repeating the screening. So it would be something closer to 7. See what the other panelists see.
Great, thank you. Well, again, I appreciate everybody staying on a little bit over today, and we tried to answer as many questions as we could. This obviously could go on almost forever, but just on behalf of everyone at Cure HHT, I want to thank you for attending today's webinar and for staying connected with us. Cure HHT is the only patient advocacy organization funding HHT research, providing education materials to patients and providers, advocating for the disease and expanding treatment centers around the world. We are truly here for you. You can contact our office at any time through the website at www.curehht.org. And we just want to remind you that if you haven't received your complimentary copy of the Comprehensive Guide to Managing Your HHT, which includes all these checklists, let us know by completing the short survey at the end of this webinar. There is a question on there if you would like a complimentary book, and we'd also like your feedback so that we can serve you better in the future. And lastly, I just want to mention that this is only one topic in the International HHT Guidelines education series. We will be covering every topic separately, and you can register for each free webinar on our website or view the recordings. And again, I want to thank Dr. Hammill, Dr. White, and Cassie Friday for volunteering their time today. This program has been recorded and will be posted on our website. We truly appreciate your participation and hope that you enjoy the rest of your day.
Thank you.